Hello, followers of Neuro Takeaway. Welcome back to the channel. Today, we are gonna see the second part of neuroimaging in oncologic treatment complications. I remind you that last week we looked over the post-neurosurgical complications, and today we will review some of the problems that can happen after the treatment with chemo and radiotherapy. Let's start with atrophy. Atrophy is one of the most frequent findings that we see years after the treatment with chemo and radiotherapy. I'd like to highlight this finding because it is usually underestimated, but the oncologists and the clinicians in general know it very well because it is associated with cognitive decline in many cases. The atrophy goes well beyond the sequela of the surgical and the radiotherapy frame. It is usually diffuse, and the mechanism is believed to be the apoptotic death of the neurons that persist for a long time, years after the finish of the treatment. Regarding the demyelinating-like lesions, they can happen with the new treatments. As you know, many years ago, some new drugs were introduced in the oncologic armamentarium. Now we have these checkpoint inhibitors, and they can produce these lesions. The mechanism of this drug is a blockade of an inhibition. The tumoral cells have the proper of produce some molecules in their surface that can inhibit the lymphocytes T. So if we block this mechanism, what we are doing is enhancing the lymphocyte T activity, the natural killers. So this may produce demyelinating disorder in some patients, in some vulnerable patients, for example, those that harbor some autoimmune disorder as MS or other connective tissue disorders. And sometimes you can see an autoimmune encephalitis in this setting. In this particular patient that had a melanoma, he received pembrolizumab, and you can see these focal lesions in both corticospinal tracts, the corpus callosum, typically demyelinating, and sometimes they can be reversible after the withdrawal of the drug. Other drug that can be associated with white matter lesions is capecitabine. Capecitabine is a prodrug of uracil, which is an antimetabolite, and this patient was a colleague of mine that had breast cancer, and she received capecitabine, and she presented with confusional state, dysarthria, and on imaging you can see these pretty symmetrical lesions in the subcortical white matter, in the corpus callosum. They had restriction on diffusion, and they reversed after the withdrawal of the drug. Methotrexate is another very used drug, especially for lymphocytic leukemias in children and young adults, and it can be associated with diffuse white matter signal intensities, but in some cases it can produce a stroke-like syndrome. This child presented with a right hemiparesis and dysarthria and aphasia. And you can see on imaging that there is not much on T2 and FLAIR, but there is a clear focal lesion in the left centrum semiovale. And this lesion is believed to be secondary to intramyelinic edema, and it is reversible in most cases after the withdrawal of the drug, but sometimes there is a tiny hyperintense signal intensity that remain on T2 and FLAIR. Regarding inflammation, inflammation is a very common sign after treatment with chemo and radiotherapy. Many years ago, a new concept was introduced, which was pseudoprogression. Pseudoprogression is the presence of edema and an increase of the enhancement after treatment. It occurs mainly inside the area covered by the radiotherapy frame. 6 months post finalization of radiotherapy is the longest time when you can see this complication, but it usually occurs in the first 3 months in almost 60% of cases. It occurs around 20 to 30% of the patients that receive chemo and radiotherapy for therapy for glioblastoma. It is usually reversible, but sometimes it can evolve into necrosis. More than 90% of these glioblastomas have the MGMT gene promoter methylation status. The vast majority of cases are asymptomatic, but sometimes, in up to 1/3 of cases, they can produce some symptoms. If they are hard, they can receive as treatment steroids, anti-angiogenic, or sometimes occasionally surgery. And this is a typical case of pseudoprogression. Here the patient received surgery, and this is the early scan, the early image that we do in the first day in order to rule out granulation tissue enhancement. You can see there is some enhancement, which is a residual tumoral cells, but in the second month, there is a more enhancement, more mass effect, and more edema. So this is the typical finding of pseudoprogression. And on the 4th month after the surgery, these characteristics improve a lot. So it's important to realize this finding, because that's why we don't perform an MR in the 2nd month. We usually defer this control to the 3rd month at least. There are some true early progression signs that we have to know. For example, the involvement of the corpus callosum or the subependymal enhancement or the multifocal enhancement are typical findings of true early progression. And on the other hand, there is some overlap between the concept of pseudoprogression and early delayed radiation injury. The difference is that pseudoprogression is related to cellular death, both of tumoral and endothelial cells, and there is an inflammatory reaction, and sometimes some authors believe that there is autoimmunity. These mechanisms lead to a blood-brain barrier leakage that leads to edema and enhancement. Meanwhile, the early delayed radiation injury is associated with peritumoral white matter damage. But as I said, you can see both things at the same time. Going on with inflammatory reactions, some drugs, especially checkpoint inhibitors, again, can be associated with inflammation of some organs. And one of these is the pituitary gland. This hypophysitis is associated with that enlargement of the pituitary gland, as you can see here, a globulous gland that enhance diffusely, and it is usually asymptomatic, but occasionally may be associated with headache or visual problems. Regarding the spinal cord, you know very well the actinic myelitis. Unfortunately, this is not a very common complication, but I like to show you this patient because it was very didactic for us. The patient was a woman, a middle-aged woman with subacute paraparesis, and we discovered this small lesion in the upper dorsal spinal cord on T2. When we went to see the axials that are extremely important, we recognized this lesion on the left side of the spinal cord, but at the same time in the adjacent arch of the vertebra, you see this hyperintensity, which was also in the rib. And then we went back to the medical record and we found that this woman had been treated with radiotherapy for a lung tumor. So this is a very important and very typical finding of radiation myelitis, and stress the importance of knowing the clinical history of the patients. Another case, this is another concept more recently described in neuroradiology. It is a concept brought from dermatology, which is the recall myelitis. Recall myelitis is the presence of a lesion of myelitis, in this case with enhancement, adjacent to vertebral changes of irradiation of the spine many years after this treatment, that occurs associated with the treatment with some drugs as paclitaxel, as in this case, or again, checkpoint inhibitors. So this spinal cord is like vulnerable to the presence of an immune reaction after receiving these drugs. And this occurs many years after the treatment. Well, it's very important to recognize lesions in the visual pathway because it is vulnerable to radiation injury. You can see here on the right side this typical radiation injury, optic neuritis, with enhancement of the chiasm, which is in the irradiation frame of this right side temporal lobe tumor that was treated with surgery and radiotherapy. On the left side, you see another complication that we described. This is what we described as the stump scar. After the enucleation for retinoblastoma, you can see this enhancement of the stump of the optic nerve many years after the surgery, and we don't have to confuse to get this enhancement for dissemination of the tumor. One important thing is that these lesions do not restrict on diffusion, and they persist for a long time without changes. There are some anti-inflammatory effects that we have to know, especially secondary to some drugs, the anti-androgenic agents. There you have the bevacizumab, which is a VEGF inhibitor, and the cediranib, which is a tyrosine kinase VEGF receptor inhibitor. They produced both a rapid decrease of enhancement and edema associated with normalization of the blood-brain barriers. And this occurred very rapid in hours after the treatment. There is a symptomatic improvement with little effect on the global survival rate. They are usually used as a secondary treatment in glioblastomas, for example, and some other gliomas. Sometimes the tumor progresses in other ways because they can't generate new vessels. They co-opt the normal vessels of the surrounding tissues, and what we see on imaging is an increase of the T2 flare and diffusion weighted signal intensities without enhancement. And finally, when we withdraw this drug, there may be a rebound effect with a huge increase of the edema and enhancement that it's very important to know. Here we have a typical case of this so-called pseudo-response with ceduranib. We have here the first slides, pre-treatment. You have a very ugly tumor in the right temporal occipital region. After the treatment, you see that there is a very rapid improvement of the enhancement, but the mass effect is increased and the extension of the flare involvement is much larger, and this is the typical pattern of the pseudo response to these anti-angiogenic drugs. Regarding necrotizing lesions, there are some, especially radiotherapy, may be associated with necrosis. There are suggestive signs as enhancement when the original tumor didn't enhance, enhancement in the irradiation frame area, but far from the original tumor, and typical patterns that we have to recognize. There are three very good friends, very well recognized patterns that are very typical of this irradiation necrosis. One of these is the soap bubbles pattern, as you can see in this first slide. This second pattern is the Swiss cheese pattern, and the last is the periventricular one. This is not the subependymal that it's very typical of a true tumor progression. This is like the periventricular white matter pattern. And this is a case, you can see here the sequela of the surgery of right side temporoparietal tumor. Here the huge extension of white matter changes secondary to irradiation, and here the presence of some foci of restriction on the corpus callosum, the periventricular white matter. There is no increase of the cerebral blood volume and the typical high lipid peak on spectroscopy. Another case, this is a right frontal tumor that developed radionecrosis. You can see here this irregular peripheral pattern of enhancement, like with an starry pattern. There is edema surrounding this focus of necrosis, and sometimes it is associated with some microbleeding. But the interesting thing of this case, there is no restriction at that level. When we performed cerebral volume maps, we found that there was no increase of this parameter at that level, but there was increase of the cerebral volume on the right frontal lobe, where we didn't see any enhancement. So the tumor was right there, and this is the typical finding of both radionecrosis and residual tumor, which is very common after the treatment of glioblastoma, which, as you know, it is a very resistant tumor, and unfortunately there is no very complete treatment. Another case of necrotizing lesions is those that occur after the use of bevacizumab. This anti-angiogenic drug may be associated with coagulative necrosis. This is a case of a thalamic glioma that received as a second line bevacizumab, and he developed this focal lesion with peripheral enhancement and a strong restriction on diffusion that it is typical of this complication that may persist for a long time, and we don't have to interpret this finding as residual tumor. Now let's go to vascular complications. There are many. One of the most common is the posterior reversible leukoencephalopathy syndrome. As you know, PRES is very frequently found in this context. This is a typical case with bilateral symmetric hypodensities on CT at the subcortical level, especially in the posterior part of the brain, but there are many atypical findings. Here you see some leptomeningeal enhancement associated with the lesions. This occurs in around 15% of cases, and the typical pattern on an MRA with the thinning and irregularity of the vessels, especially of the posterior circulation. There are many drugs associated with PRES, so I prefer not to describe them, but many chemotherapy agents may be associated with this complication. Let's go to actinic arteritis. As you know, some tumors, especially those that occurred in the base of the cranium, this is a craniopharyngioma with residual lesion at the suprasellar level, with calcifications that you see dark on T2, that was controlled by us many years after the treatment, and we can see here this residual actinic cerebralitis in the radiation frame. But we found this tumor. This was kind of surprising for us. In the middle cerebral artery territory, and on MRA we found this arteritis at the level of the middle cerebral artery. This complication is rare, but it can occur, and it can have a moya-moya-like pattern in some occasions. Another case of actinic arteritis. This was a patient with a neck tumor that was irradiated, and he developed some years later right frontoparietal embolic stroke, ischemic stroke. This is an acute lesion, and you can see both on MRA and digital subtraction angiography the presence of irregularities in both internal carotid arteries with segments of dilation and segments of stenosis. I want to highlight the importance of this finding and the difficulties that we have with the treatment of them, because they are not amenable to endovascular treatment, because the walls of the arteries are fragile, so they have to be treated with caution with surgery. Now let's go to some other very frequent complications after radiotherapy as microbleeds, cavernomas, and calcifications. They are both The three of them are associated with arteritis, but in this case of the small arteries. Here you see a patient that had received radiotherapy many years ago because of a medulloblastoma, and he developed calcifications pretty symmetrical in the subcortical white matter and in the basal nucleus. On the right side, you see a patient with cavernomas in different places. This is a type 1 cavernoma of the Sabransky classification with recent evidence of recent hemorrhage. These complications are usually asymptomatic, but sometimes can be associated with headaches or seizures. Some drugs may produce venous thrombosis, and one of these, the most common one, is the L-asparaginase. L-asparaginase is used for the treatment of acute lymphocytic leukemia, and this is a child with hemorrhages in both sides of the brain. And when we performed CT and venous angiography, which we do in all these cases, because this is a very frequent complication of this drug, we found a thrombus at the level of the superior sagittal sinus. And these patients have to receive anticoagulation because this drug is very useful, and they usually keep on with the treatment with this drug. Another relatively new complication, at least we are recognizing it more and more lately, is SMART. SMART stands for stroke-like migraine arteritis secondary to radiotherapy. This was a patient with headache and focal seizures years after radiotherapy for pineoblastoma. You see here hyperintensity on flare on the right temporal parietal lobe with gyron enhancement and enhancement of the leptomeningeal vessels. There is not much restriction. This is typical of these cases, but you see here a little focus of a restriction. On MRA, you can see hyper or hypo flux at the level of the lesion, and on the perfusion maps, you see here a hyperperfusion area, which is typical of this process. This is usually reversible, but sometimes it can recur. Let's go to another complication, as it's the opportunistic infection. Opportunistic infections, unfortunately, are not rare because these patients sometimes receive immunosuppressive drugs. One of the most common germs that we see is Aspergillus fumigatus. Aspergillosis is an opportunistic infection that may present with different patterns. One of the most frequent one is the presence of granulomas. This is a typical granuloma with a peripheral restriction area that usually enhances a lot, and the center of the lesion is liquid and there is no restriction. This is the typical finding, but sometimes we had the opportunity to see a combination of different patterns with abscesses, typical abscesses, granulomas, infarcts, because this is an angio-invasive fungus. It's important to look at the CT of the lungs, because there sometimes you see typical lesions as well. Other complication that you can see is the presence of tumors. For example, in this child, which had been treated for medulloblastoma, a typical type 4 medulloblastoma without much enhancement. And here you see years later the presence of another lesion at the right middle cerebral peduncle with enhancement. The biopsy revealed that this was a GBM. Another case of a child with an ependymoma of the right cerebropontine angle with extension to the Luschka foramen and to the fourth ventricle. This is a typical location for an ependymoma. He received radiotherapy, and you can see here the injury of the white matter as well as the consequence of radiotherapy on the skin with hair loss and the presence of this sarcoma. Another patient treated for a bilateral retinoblastoma with irradiation, and now this treatment is no more the rule. We don't irradiate these patients anymore, but many years ago it was the treatment of choice, and the consequence of this treatment was the development of this osteosarcoma on the left side. These patients with bilateral retinoblastoma have genetic alteration that make them more vulnerable to the development of secondary tumors. And finally, another tumor. This is a lymphoma. This is a typical case of post-transplant lymphoproliferative disorder. In general, these tumors appear after solid organ transplants, as the kidney transplant or heart transplant. But in this occasion, it was secondary to a bone marrow transplant for an acute myeloid leukemia. We had the opportunity to see this boy who developed a focal lesion with high density on CT, restriction on MR, edema, the presence of hemorrhage that we found this in some patients with this complication. And these lymphomas developed in association with an Epstein-Barr virus infection. Well, now to finish up, let's go to the complication of the spine. You know that after the irradiation of the spine, we see changes in the bone marrow. These typical patterns are very, very common after the treatment of metastasis. We see the lesions that may be active or not, but in the background of the spine, you see this diffuse hyperintensity on T1 and hypointensity on STIR, which represent the infiltration with yellow bone marrow, and these patients are vulnerable to develop fractures and deformities. On the other hand, we have to recognize these conversion and reconversion patterns that should not have to be confused with infiltration with the tumor. Another complication of radiotherapy is the osteoradionecrosis. Osteoradionecrosis is it's very important to differentiate from metastasis, because they are focal lesions in general with geographical borders. They enhance a lot with contrast because they have fibrous tissue replacing the bone. Well, this is all that I have to tell you. I would like to highlight the switch that is happening nowadays in oncology. We are going to a precision oncology treatment where we treat each and every patient and each and every tumor in an individualized way. With this, I would like to thank you and see you next week. Bye-bye.